Hi, my name is Marie Navar. I'm the Secretary of the American Society for Preventive Cardiology and a preventive cardiologist and associate professor at UT Southwestern. I'm delighted to present this year in review with a focus on preventive cardiology from 2025. So let's jump right in. The first topic that we saw a lot of really exciting new data on was for GLP-1 receptor agonists and treatments for obesity. A key trial in 2025 was the much anticipated SOUL cardiovascular outcomes trial for oral semaglutide. The first thing that we saw is over a prolonged period of time, modest but important reductions in hemoglobin A1C and a difference in weight in the placebo compared to the placebo arm of about 3 kilograms. But what was more impressive was that oral semaglutide also led to statistically significant reduction in major adverse cardiovascular events, including non-fatal myocardial infarction and non-fatal stroke and death from cardiovascular disease. We also saw expansion of the role of semaglutide beyond ASCVD from a coronary disease standpoint, now focusing on peripheral arterial disease. This was the STRIDE study, which was also published and presented in 2025. The objectives of the STRIDE study were to evaluate subcutaneous semaglutide and its impact on walking distance in participants with symptomatic peripheral arterial disease. What the investigators found is that compared with placebo, individuals given semaglutide had significant increases in their maximum walk distance over time compared with placebo. And when evaluated as a composite, looking at initiation of medication for claudication, revascularization, major adverse limb events, or all-cause death, reductions in the total of all of those in those given semaglutide compared with placebo, extending this important class of therapies to individuals with symptomatic PAD. Now, many individuals are using these drugs for weight loss and obesity management. And one of the challenges that we've had is which drug should we pick? Well, 2025 also gave us a head-to-head comparison of tirzepatide and semaglutide for weight loss. And the SURMOUNT-5 investigators showed that tirzepatide led to statistically greater weight loss than semaglutide, with a 20% reduction in body weight for tirzepatide compared to a 14% reduction for semaglutide, highlighting that tirzepatide seems to cause more weight loss than semaglutide. But importantly, a 14% reduction in weight for semaglutide, also reminding us that we have multiple options now for pharmacologic management of obesity. 2025 also brought us progressive research on new therapies for weight loss that are under development. We have phase 2 and 3 trials for several new medications that lower weight with promising data as these continue to advance. And there are ongoing studies still happening with even more agents, as you can see on this slide, including retatrutide, survodutide, and CagriSema. Hypertension control is a key part of preventive cardiology, and perhaps the highlight of a year from a hypertension standpoint was the release of the 2025 ACC-AHA Multi-Society Guideline for Hypertension Control. Key things in this guideline, in my opinion, that are important as we continue to manage blood pressure in clinical practice are that first, that we replace the pooled cohort equations with the PREVENT equations for risk assessment, a reinforcement of a goal of less than 130 over 80, even in low-risk individuals if lifestyle fails, and in a reminder that in people with elevated blood pressures of over 140 over 90, that we really should be starting with 2 agents, ideally in combination. These guidelines also emphasize and recommend expanded screening for primary aldosteronism, an important cause of secondary hypertension. 2025 also brought us more data on zilebesiran. Zilebesiran is a small interfering RNA that's a long-acting medication that targets angiotensinogen and is injected subcutaneously every 6 months. The KARDIA-2 trial showed us that when added to a background of indapamide, amlodipine, or olmesartan, zilebesiran led to important reductions in blood pressure, though it varied depending on what the background agent was used. We also saw data from the KARDIA-3 trial in individuals who were on 2 or more medications. Although it was not statistically significant, there was a 5 milligram mercury reduction in blood pressure in those given zilebesiran compared with placebo. These data were sufficient to lead to the announcement of a cardiovascular outcomes trial for zilebesiran, which is now underway. We also have another new agent for blood pressure control, which is baxdrostat. Baxdrostat is an aldosterone synthase inhibitor. It's a once-daily oral medication, and compared with a placebo, had remarkable reductions in blood pressure. Compared to baseline, individuals on 2 milligrams a day of baxdrostat had a 16-point reduction in blood pressure, which was about a 10-point difference relative to placebo, with very low rates of hyperkalemia in those given the medication. We also saw advances in the treatment of lipoprotein A. The phase 2 data, the phase 2 trial, Alpaca, showed the effect of different doses of lepodisiran every 6 months to a year in individuals with high lipoprotein A, finding sustained and significant reductions in lipoprotein A of greater than 95% when dosed at 400 milligrams every 6 months. The acclaimed lipoprotein A cardiovascular outcomes trial of this drug is still ongoing. We also saw data on a new mechanism to lower lipoprotein A. Current therapies focus on preventing the synthesis of ApoA in the liver. Muvalaplin is a unique novel mechanism that binds to ApoA and prevents it from binding to the ApoB on an LDL particle, preventing the assembly of lipoprotein A particles. In the Kraken trial, we observed an over 80% reduction in intact Lp(a) in individuals who received muvalaplin. And after these data were published, we heard about the announcement of the MOVE-LPA cardiovascular outcomes trial, which launched in 2025 and will test whether or not this drug can lower cardiovascular events in individuals with high LPA. Speaking of trials in LPA, we were disappointed not to see the results of the first LPA lowering cardiovascular outcomes trial, the Horizon trial, which is still ongoing as of the time that we record this lecture, though we do anticipate these results to come in 2026. So for those of us who were hoping to get the first outcomes data for LPA lowering in 2025, we were somewhat disappointed, but are excited to see what 2026 will bring. No talk in preventive cardiology will be complete without talking about LDL cholesterol. And perhaps the most pivotal trial in preventive cardiology across any of these domains was presented at 2025's American Heart Association Scientific Sessions, and that was the Vesalius trial. Now, we know previously that PCSK9 inhibiting monoclonal antibodies reduce cardiovascular events in people who have a prior heart attack or stroke. The Vesalius trial sought to evaluate whether evolocumab would prevent events in people who had not had a prior event, and that included individuals who either had evidence of atherosclerotic cardiovascular disease without a prior MI or stroke, or individuals at high risk of disease who also had diabetes. As expected, we saw significant reductions in LDL cholesterol in individuals treated with evolocumab compared with placebo. And I'll highlight that the starting LDL cholesterol in the Vesalius group was fairly high at about 110, but that when we treated individuals with evolocumab, the median LDL cholesterol at 48 weeks was 45 milligrams per deciliter. So we're taking these individuals down to LDL levels less than 55, much lower than what prior guidelines had recommended for primary prevention. And what was shown in the trial was an impressive 25% reduction in 3-point MACE in individuals given evolocumab compared to placebo, with consistent reductions in all of the endpoints that were studied. And although it didn't meet statistical significance due to the order of hierarchical testing, we did see a reduction in all-cause mortality in this population, which was an impressive finding given that this population was lower risk than had been studied in prior cardiovascular outcomes trials of PCSK9 monoclonal antibodies. This trial is likely to move the field to continue to treat individuals with both ASCVD as well as subclinical disease and high risk of ASCVD to even lower LDL targets than we had previously thought were necessary to prevent cardiovascular disease. We also have 2 new oral therapies that inhibit PCSK9 that we saw data for in 2025. Enlicitide is a macrocyclic peptide, which blocks the interaction between PCSK9 and the LDL receptor, and 2 large phase 3 trials showed about a 60% reduction in LDL cholesterol in individuals taking this once daily medication, and the outcomes trial for this drug, the Coral Reef Outcomes Trial, is continuing. We also saw data for AZD0780. This is a small molecule, which works a little bit differently. It prevents the PCSK9-induced LDL receptor degradation. And in a phase 2 trial of individuals on statins, this medication lowered LDL cholesterol by up to 51% at week 12. We also saw data for obicetrapib. Multiple phase 3 studies presented in 2025 showed obicetrapib led to meaningful reductions in LDL cholesterol compared with placebo in individuals with heterozygous FH or ASCVD, either alone or in combination with ezetimibe. And pretty exciting, we also saw that when those data were pooled from 2 of the phase 3 trials of obicetrapib, there was a signal that it may also reduce the risk of new onset diabetes. The PREVAIL cardiovascular outcomes trial for obicetrapib is continuing, and in future years, we hope to be able to see those data as well. We also saw presented impressive phase 1 data for gene editing for LDL cholesterol. This study was using CRISPR-Cas9 to gene edit, targeting ANGPTL3 for LDL cholesterol lowering. And individuals who underwent the therapy had significant reductions in LDL cholesterol, which persisted for up to 180 days after the infusion, with a relatively safe side effect profile. The final topic that I'll discuss is inflammation. And we knew from prior trials that colchicine appeared to have a benefit for cardiovascular protection in people with prior cardiovascular disease. Interesting though, the CLEAR trial, which tested colchicine in individuals who had acute myocardial infarction, found no overall benefit in individuals given colchicine compared with placebo. Although, interestingly, when stratified by whether or not individuals were participating before the COVID pandemic, during, or after the pandemic, it appeared that there was a benefit in individuals who received this before COVID-19, raising questions about whether or not this drug may actually still be beneficial if it were not for the noise of the COVID pandemic. The test of inflammation is going to continue in 2026. Ziltivekimab is an anti-IL-6 monoclonal antibody that targets inflammation and reduces hsCRP. The design paper for the ZEUS trial was published in 2025, and the results of the ZEUS trial evaluating whether ziltivekimab will reduce recurrent events in individuals with ASCVD and CKD is anticipated to be released in 2026. So we've had a really exciting year in preventive cardiology with advances across multiple risk factors and ongoing outcomes trials that will continue to make future years in review interesting and hopefully practice changing. Thank you for tuning in.